Hi guys, my name is Ben, and today we're going to be talking about sepsis and shock. So I'm a medical student at the University of Liverpool, currently intercalating between fourth and fifth year. And yeah, sepsis and shock, both really important conditions to know about, and come up in most of my exams since second year, come up in OSCEs as well, so really important. So I did this talk for LACES a couple of weeks ago, but unfortunately we had a few technical difficulties. My Wi-Fi ended up kicking me out. And for those of you who attended, you'll know didn't run that smoothly, so just asked me to re-record it. So we'll just go through it a little bit quicker today because we won't have that interaction. But we'll cover all the same points, the same slides that I used on the day. If you've got any questions, feel free to email me after. So my email address is there. And yeah, thank you to LACES for having me on. So just what we're going to cover today. To start with sepsis, the key definitions, risk factors, how to diagnose and manage it. And then we'll move on to shock again, talk about some key definitions, talk about the different types and subtypes of shock, and how to diagnose septic shock in particular. And then we'll do a little quiz at the end just to recap. When we did it the first time around, we did a poll. Everyone did really well. I think most people got all the answers right. It's just a good one just to test yourself on the end. So why sepsis is so important? So sepsis is a massive killer in the UK and worldwide. It accounts for a fifth of deaths annually per year, 25,000 emergency paediatric admissions. 5 people die every hour in the UK, which I know is quite a shocking stat. And the takeaway point here really is even if patients do manage to manage it and come out the other side, then there's still long-term lasting effects in almost half the patients. So yeah, 40% of all sepsis survivors will suffer permanent life-changing effects. So the emphasis really should be on prevention of sepsis rather than catching it early and managing it. It's really important that it doesn't get to that point where a patient becomes septic in the first place because that can be quite damaging long-term effects. So what is the definition of sepsis? Sepsis is severe organ dysfunction caused by a dysregulated host response to an infection. So essentially, patient picks up an infection and their immune system goes into overdrive, and you get systemic widespread effects. So it used to be defined using SIRS, which is systemic inflammatory response syndrome. They don't use this anymore, but I know at University of Liverpool and CCT and CBL sessions it still gets mentioned. The term SIRS still gets thrown about, so it's a good one still to know about. So SIRS is 4 criteria, and you need 2 of them. I typically use 2 of them to diagnose sepsis. So there's tachypnea, or a respiratory rate over 20, a mildly elevated heart rate, so heart rate over 90, hypothermia, so temperature under 36, or hyperthermia, so over 38 degrees Celsius, or a low white cell count below 4,000 or over 12,000. So 2 of those typically mean sepsis with a proven infection. Most common causes of sepsis, so GI infections are the most common. Also got lower respiratory tract infections, commonly strep pneumoniae being a big cause. UTIs are a massive one on the increase, so causing more and more cases of sepsis nowadays, E. coli being a really big cause of those. And one I just thought I'd mention is Group B strep. So this is a really important one to consider when you see a case of neonatal sepsis. So it's quite an important exam question, it gets asked a lot. So Group B strep is an infection that's carried in the genital tract of the mother, and if they're high risk for Group B strep infections, say they've had an infection before, or if their membranes rupture, I think it's over 18 to 24 hours before labour, or they develop a fever during labour, then they'll be screened for Group B strep with a swab, and any patients who test positive will receive IV benzyl penicillin during labour to produce the transmission through the birth canal. But yeah, Group B strep, really important one to consider. Always think neonatal sepsis, Group B strep. So the name of the criteria used to diagnose sepsis is the Q-SOFA criteria. and Q-SOFA criteria. So again, you need 2 of them plus a proven infection to diagnose sepsis. There are 3 criteria and they do differ from the SIRS. So the first one is an altered mentation. I know some people like to use the Glasgow Coma scale to determine mentation. I know it's typically designed for head injury patients, but people kind of use it for more things now. Just confusion generally. Think sepsis. Again, a tachypnea. The ceiling slightly higher on this one than it is for SIRS. So this is respiratory rate over 22. And finally, hypotension, so systolic blood pressure under 100. Risk factors for sepsis, so age, extremities, the patients under 1, like we mentioned just a couple of slides ago, the neonatal sepsis and the group B strep infection, but also very elderly patients over 75 years old. Any patients who are immunocompromised, obviously at greater risk of developing an infection in the first place. So cancer patients who might be receiving chemotherapy, patients who've got immunosuppressive comorbidities such as diabetes, sickle cell disease, patients who've had their spleen removed. And then another really important cohort of patients to remember is those who've got autoimmune conditions such as rheumatoid arthritis. So they're typically receiving kind of lifelong or long-term immunosuppressants such as long-term steroids, methotrexate, azathioprine, which will increase their likelihood of developing infections. Patients who've had surgery or invasive procedures such as endoscopies within the past 6 weeks, or any patients who have had a termination of pregnancy or have given birth in the past 6 weeks as well. And there's also patients who have had a breach of skin integrity, so burns patients commonly. Sepsis is quite common amongst those. There's a whole host of risk factors. There's nice guidelines. I've got tables to kind of categorise them. We'll talk about them later. But they're just some of the ones to consider. Signs and symptoms of sepsis. I'm not going to dwell too much on this one because we've kind of covered the Q-SOFA criteria, which I think is more important in recognising sepsis. I thought I'd put this in just so people are aware that sepsis can present in a whole wide variety of ways. It can be very non-specific, and not to get thrown if you do see a presentation that makes you think, oh, that's a bit weird, maybe not sepsis. It can present in many ways. Typically it present with signs and symptoms of the infection that they originally developed, whether it's a urinary tract infection or whether it's a chest infection. Common signs and symptoms, so obviously with any infection, fever and malaise is common. Confusion, which we mentioned, the altered mentation comes under the Q-SOFA criteria, as do hypotension and tachypnea. Tachycardia we mentioned with the SIRS criteria as well. And then a few slightly different ones you might not expect. Patients may become cyanotic, may become hypoxic or edematous. You can see the cyanosis and the edema in the pictures in the top right corner. This is due to the lack of perfusion, not perfusing their lungs adequately or their vital organs, not getting enough blood flow to the peripheries, so it can present in these ways as well. Thought this was just a good one. I know medical students love their mnemonics and their acronyms, so I put this one in. This is on the Sepsis UK page. So this is sepsis, so slurred speech or confusion. Again, we mentioned with the Q-SOFA. Extreme shivering or myalgia, you'd expect that again with any given infection. Passing no urine, so oliguria, anuria is a really important one. We'll talk about this a bit later when we talk about the sepsis 6. Severe breathlessness, it feels like you're going to die, so it's life-threatening, it's really, really serious, and skin mottling or discoloration. And this is just from the NICE guidance. This is a high, moderate and low risk criteria for sepsis. You don't necessarily have to learn this off by heart, but sometimes, particularly in OSCE, they might put this in front of you and then give you a case and maybe ask you how you'd manage the patient, or is this patient high risk? So it's just something to be aware of. Sepsis diagnosis and management. So what are the sepsis 6? So there's a couple of different ways. I know people like to remember it. The way I like to do it personally is give 3, take 3. So first of all, you're giving 3 things. The first being IV antibiotics. So broad spectrum. There's no specific regime you'd use for sepsis alone. It'll vary depending on the origin of sepsis or the trust guidelines. The key being broad spectrum antibiotics. And you want to be giving them as soon as possible. If you suspect sepsis, you want to be cannulating them straight in with antibiotics. The cut-off point, they say, is within an hour of admission. Secondly is IV fluids. So you want to be giving a rapid bolus, typically 500 mils of a crystalloid such as sodium chloride over 15 minutes, so really rapid infusion. You want to be bolstering the blood volume, increasing the blood pressure and the circulation and perfusion. And then oxygen therapy, this is for patients who are hypoxic, and you want to be maintaining those SATs between 94 and 99%. So after you give 3, you take 3. So the first is serum lactate. We'll talk about this a bit later when we talk about shock. But lactate is a really important determinant of the severity of sepsis and whether a patient is shocked. Urine output. So as we mentioned before, patients who are septic may be oligoureic or anureic. And if you think the kidneys receive about roughly a third of the total blood flow. So measuring urine output is a really good indicator of how well the patient's perfusing the vital organs, and also it's a good indicator of how well the IV fluids are taking effect. So if you've given them that rapid bolus and they're still under perfused, they're still not producing adequate amounts of urine, then you might think, okay, we need to bolster the fluids a bit more. So urine output's a really important one. You want to be doing this every hour. And then blood culture is probably the most obvious one. It gives the sensitivity to antibiotics, and make sure you're giving them the right ones. Another way that people like to remember them is buffalo. So again, it's just the same things but a different way of remembering it. So it's buffalo with 1F. It's the blood cultures, urine output, fluids, antibiotics, lactate and oxygen. I personally prefer the give 3, take 3 just because it's a bit more logical and you have to work through it, but buffalo works just as well to remember it. So what is the definition of shock? So shock is defined as inadequate tissue perfusion, so an inability of a person's cells to use oxygen correctly. And the types of shock, so there's 3 kind of broad categories. So the first is hypovolemic, which is by far the most common, and this is just when someone has a low blood volume, so whether they're hemorrhaging, if they're dehydrated, they haven't taken enough fluids in that day, or whether they may have diarrhea and vomiting, so they're losing loads of fluids. This has got the best prognosis, it's the most easily managed. You simply just give them fluids, whether it's oral rehydration solution, you want to be giving them IV fluids if they're shocked, really bolstering their blood volume up and boosting the blood pressure. Cardiogenic shock, so this is when cardiac output is insufficient, so not pumping enough blood around the body, and this is quite common following myocardial infarction. And then vasodilatory, which is a bit of an umbrella for some of the more commonly known subtypes. So this is when you get widespread vasodilation and it causes blood to pool away from the heart. So septic shock would come under this. You also get neurogenic and anaphylactic shock too. So what are the criteria for diagnosis of septic shock? So there's persisting hypotension requiring vasopressors to maintain a mean arterial pressure of 65 milligrams of mercury. So adrenaline being an example of a vasopressor. And as I was mentioning before with the lactate, it's a really good marker of whether someone is shocked and how severe the sepsis is. So serum lactate over 2 millimoles per litre would be significant to define shock. Don't know if you remember, there was a case a couple of years ago where a consultant missed a really high lactate in a child. I think it was as high as 8 or something like that. Sadly, the patient died, and there was a big legal case over it. So lactate is a massive one, really important one, comes under the sepsis 6, used to define shock. Should never ever forget the lactate. On to anaphylaxis now. This is a severe generalized or systemic type 1 hypersensitivity reaction, which means that it's mediated by IgE antibodies. and it's characterised by really rapid onset, life-threatening airway compromise, and the cardiovascular and respiratory systems may be affected as well. So key diagnostic features of anaphylaxis, so it's that really rapid onset. So angioedema, you can see in the picture there, the swelling of the lips. You can also get kind of periorbital angioedema. You can get peripheral angioedema. Stridor, shortness of breath, wheezing, typical of airway obstruction. Also might become cyanotic. Hypotension, as we mentioned, it's a vasodilatory type of shock, so that widespread vasodilation would cause the blood pressure to drop. They also might get dermatological manifestations, so urticaria, which is hives, erythema, and they may be very itchy as well. So the blood test used in the diagnosis of anaphylaxis, which is mast cell tryptase. Obviously, if you expect or you suspect someone to be anaphylactic, you're not going to mess around and be doing blood tests on them. You're going to be treating them right away. And this can be done afterwards just to confirm the diagnosis. And it's typically raised 1 to 2.5 or 1 to 2.5 hours, after the exposure to the allergen. So what is a dose of adrenaline given in anaphylaxis, and what is a route of administration? So those of you who use past medicine will see this one coming up a lot. So yeah, adrenaline, should have mentioned, that's the management for anaphylaxis, and it's 0.5 milligrams in a 1 in 1,000 solution. And it's typically given as an intramuscular injection, so really rapid onset and mechanism of action. Briefly touch upon cardiogenic shock. I don't think it gets spoken about much during medical school, or I certainly kind of saw it less than the other types. A lot of the principles kind of apply to shock or medical emergencies generally. Then there's a few that are more specific to cardiogenic shock. So in a medical emergency, obviously the first thing you're going to be doing, A to E assessment and treating the underlying cause. And then there are some therapies, adjunctive therapies you can use. You wouldn't necessarily use all of them. It'd be context specific. But firstly, there's vasopressors. We mentioned adrenaline before. These are vasoconstrictors, and they act to boost the mean arterial pressure. IV fluids, again, cardiogenic shock. So that's the failure of the cardiac output essentially. So this would be boosting the blood volume, boosting the blood pressure, and just improving that circulation generally. Nitroglycerins, this is the opposite to vasopressors. It's actually vasodilates with the aim of increasing perfusion. Inotropes, so these act to kind of improve the contractility of the heart, so increase the force of which the heart is pumping out. So dobutamine would be an example of an inotrope. And then finally, last resort, last line being intra-aortic balloon pump. So onto the recap quiz now. So we flew through that really quickly. Obviously no one attending live, so I can't have people answering the questions. But yeah, the recap quiz. So the first question is, which of the following would be classified as a broad spectrum antibiotic therapy for sepsis? So as you mentioned before, broad spectrum antibiotics need to be given, I won't say within how long. I think that's a question coming up. But yeah, out of these options, it's going to be tazocin and gentamicin. So this question really is kind of a process of elimination. So just looking through the options, starting with flucloxacillin, as penicillin, commonly used for skin and soft tissue infections, has more of a localized effect, wouldn't be classified as a broad spectrum antibiotic. Onto the second one, so benzyl penicillin, we did mention, is used IV in the management of group B strep, given during labour to prevent that transmission from the genital tract. But nitrofurantoin wouldn't typically be classed as a broad spectrum antibiotic. It's commonly used in urinary tract infections, give quite a narrow spectrum of treatment really, so you could rule that one out. Tazocin and gentamicin would be the best of those options, and gent being an aminoglycoside. Tazocin is commonly used in neurosepsis, but can be used in others as well. And then phenoxymethyl penicillin and trimethoprim. Trimethoprim, again, like nitrofurantoin, is typically quite limited to urinary tract infections, phenoxymethyl penicillin or Pen-V, commonly used in throat infections, tonsillitis, stuff like that. So a bit of a process of elimination, the best option of which would be tazocin and gentamicin. Question 2. As part of the sepsis 6, within what time frame must treatment be given? 15 minutes, 30 minutes, an hour and a half, or 2 hours? So this one is an hour. I think everyone got this one right when we did the quiz live. So yeah, you don't want to be messing around. You want to have them cannulated, antibiotics as soon as possible, and get to the bottom of that infection. So this one, just a small case. You've got a 65-year-old patient presents with chest pain, fever, and a productive cough. He then becomes septic. What is the most likely bacterial cause? So I know this is quite a common one in Liverpool med school exams. They like to ask kind of bacterial causes, most common organism. So E. coli, Neisseria meningitidis, Legionella, or Streptococcus pneumoniae. Yeah, so it'd be strep pneumoniae. Typical pneumonia picture, elderly patient, typical symptoms, chest pain, purulent sputum production, fever. So E. coli commonly causes kind of gastrointestinal infections, urinary tract infections. You wouldn't really expect that picture. Neisseria meningitidis, meningitis, meningococcal septicemia. Legionella is an atypical cause of pneumonia, but it wouldn't really give this kind of classical pneumonia picture. Presents a bit more non-specifically. You get electrolyte abnormalities like hyponatremia. You get dermatological manifestations as well with it. Strep pneumonia would definitely be the most common cause of pneumonia, elderly patient here. Question 4. Which of the following is not included in the Q-SOFA criteria for sepsis? And this one, yeah, would be the heart rate over 90. So this was part of the SIRS criteria, not part of the Q-SOFA. So yeah, the ones to remember is the altered mentation, the tachypnea, and the hypotension. What blood test is used in the diagnosis of anaphylaxis? Mast cell tryptase, serum trypsin, serum lactate, or serum lipase? Give you all a second if you wanted to pause it and answer them in your head. So this would be mast cell tryptase. Put these other ones in as kind of red herrings. I think I had a mock once and I ended up putting trypsin instead of tryptase, pancreatic enzyme. Serum lactate we did mention as the indicator of septic shock, but it wouldn't be used to diagnose anaphylaxis. And serum lipase is another red herring. And finally, what dose of adrenaline is given in anaphylaxis? 5 milligrams in a 1 in 1,000 solution, 3 milligrams in a 1 in 1,000 solution, 1 milligram in a 1 in 1,000 solution, or 0.5 milligrams in a 1 in 1,000 solution. It is 0.5 milligrams in a 1 in 1,000 solution. Yeah, typical past medicine question, this one. Important one to learn, really easy one for them to just throw in an exam. Easy one to slip up on as well, so it's really important to kind of nail that one down. Just the takeaway points, so sepsis is a dysregulated host response to an infection resulting in systemic organ dysfunction. Commonly diagnosed using the Q-SOFA criteria, which were hypotension, tachypnea, and altered mentation. It's managed using the Sepsis 6, so give 3 broad-spectrum antibiotics within an hour, oxygen therapy, and IV fluids are typically the rapid bolus, 500 ml of sodium chloride over 15 minutes. And you're also taking 3, so blood cultures, serum lactate, which is the marker of septic shock, and urine output. Management must be commenced within an hour of admission. Septic shock, we just mentioned again, so it's requiring the vasopressors to maintain that mean arterial pressure, 65 milligrams of mercury, and a serum lactate over 2 millimoles per litre, so it's both of them are required to diagnose septic shock. Anaphylaxis, it's the IgE-mediated hypersensitivity reaction. It's managed with intramuscular adrenaline, 0.5 milligrams in a 1 in 1,000 solution. Thank you very much. Thank you to everyone who attended live and for all your questions afterwards, and the feedback's really appreciated. Sorry, that was a really kind of whistle-stop tour, septic and shock. If you've got any questions, feel free to email me. Obviously, you can watch this one back and pause it and do the questions yourself. But yeah, thank you very much. Best of luck in your finals and all your exams. Cheers.